Hello, so this is a recording on physical examination of the cardiovascular system. So this recording is intended for students that are pursuing Bachelor of Science in Nursing. So those that are taking adult medical nursing and adult medical surgical nursing can use this particular video. So the video is intended for those that have already covered the initial aspects of cardiovascular examination. That is, they've looked at the common signs and symptoms as well as the history taking in cardiovascular disorders. So this video focuses on the physical examination. So basically, after obtaining the full comprehensive history, then we should now be able to conduct a systematic physical examination with particular attention to the heart, and that includes the using the four techniques of assessment: inspection, palpation, percussion, and auscultation. I should, however, mention here that oftentimes percussion in cardiovascular assessment, this particular technique is not used very commonly because it is a technique of low sensitivity, really. Some will talk about percussing the borders of the heart, but it is not routinely performed. So to perform the physical examination of the patient with a suspected cardiovascular disorder, we can perform it in three positions. The patient can sit, or the patient can be in a lying position, okay, where they can be in supine position, or they can even be in the left lateral position as we perform this examination, okay? Now, in terms of equipment, the key pieces of equipment that we need will be the stethoscope, a sphygmomanometer. Then we need a watch that has a second hand so that we're able to count the heart rate. And then we need a tape measure that we can use to measure, for example, the anterior posterior diameter of the chest. And in case we find any abnormality, maybe a mass, we are able to measure it using the tape measure. But also, most importantly, we use the tape measure when we are checking for raised jugular venous pressure, as you shall see in this video. So the general approach to heart assessment really is that you need to explain the procedure to the patient, explain what you're going to be doing and how long it will take so that your patient can cooperate and be relaxed. Ensure that the room is warm. It should be quiet and well lit. It should be warm because you're going to be assessing your patient for warmth of the extremities, for example. And if the environment is warm, your patient will have peripheral vascular constriction and the extremities might feel cold, which you might mistake for a pathological manifestation, when in fact, it's a normal body reaction to a cold environment. So make sure it's warm enough. It should be quiet because you'll be listening to sounds using your stethoscope, and you need a quiet environment for that. It should be well lit so that you are able to visualize the various movements on the chest wall, and also so that you can clearly see, for instance, venous distension, jugular venous distension. You need a well lit environment. Expose the patient's chest only as much as needed for the assessment. Do not overexpose your patient or expose your patient unnecessarily. Then you position the patient in a position that will be comfortable. For those that are having difficulties in breathing, you may have to elevate the head end of the bed at least at 45 degrees so that you can relieve the dyspnea. That is for patients that have orthopnea. So you begin with a general survey. Normally, in the general survey, you want, if your patient is on a bed, this is a time when you would want to go to the foot end of the bed and observe the patient. But remember that the general survey begins just the moment you are approaching your patient. or as the patient is approaching you, you're already performing your general survey. So do they look ill? Okay, in which way do they look ill? Do they appear, oftentimes if patients have problems with oxygenation, they'll have an anxious appearance. Okay, patients with severe heart problems may have this vital fatigue, so they'll look tired, okay, and exhausted. Are they short of breath at rest? That could be a sign of heart failure. Do they sit in a tripod position where maybe they sit with the two hands leaning forward, supported on the bed, and the third point is the sacrum? So that's a tripod position, which most patients will assume when they have difficulties with breathing. Do they appear to be cyanosed? What is their nutritional status? Are they obese? Obesity is a risk factor for a lot of cardiovascular problems. Do they appear overweight? Are they cachexic, underweight with muscle wasting? Oftentimes, when patients have had long-standing cardiac problems, they tend to lose weight because maybe they've had ascites, accumulation of fluids in the abdominal cavity, which causes a feeling of abdominal fullness. So they'll just eat a bit of food and they feel full. Okay, so they'll begin to lose weight eventually. Do they have features of any genetic syndrome such as Turner's syndrome, Down syndrome, or Marfan syndrome? With Marfan syndrome, you may see a tall, slender person with the span of the arms. If you ask them to hold out their hands as if they are making a cross, and you measure the distance from the left finger across the chest to the right middle finger, you find that that distance will be longer than the height of the patient. Or if the patient is standing, you may find that their hands will hang so low that they may even go up to the level of the knees. They'll go beyond mid-thigh and up to the level of the knees, meaning the hands are so long. That could be a patient who might have Marfan syndrome, and it predispose them to so many cardiovascular events such as aneurysms. So in terms of inspection now, when you come closer to your patient, you want to inspect them. What do you look for when you look at the head and neck? So normally elevate the client's head up to 30 or 45 degrees or up to 90 degrees if venous pressure is elevated. For patients that have heart failure, you might want to prop them up so that it is easier for them to breathe. So inspect the tongue for central cyanosis. Central cyanosis might be present in patients that have congenital heart disease, pulmonary diseases that cause impaired ventilation. Okay. Then you want to inspect the eyes. So look at the eyes for any signs of hypercholesterolemia and hyperlipidemia, such as xanthelasma and corneal arcus. I'll show you a picture of these. So this is what we call xanthelasma. There appears to be patches of fat deposit around the eyes. These are a sign of hypercholesterolemia. Then in this diagram, you can see that around the cornea, there's this yellowish ring around the cornea. This is due to deposition of fat, and it is what is called corneal arcus. All right. So you also want to inspect both sides of the neck for distended neck veins. And I'll show you in a diagram how this is done. Usually when the jugular veins are distended, it is a sign that the right side of the heart is failing. So the blood is being shunted back from the right atrium into the superior vena cava and all the veins that are emerging from there. So that will include your jugular veins. So how do we estimate jugular venous pressure? Basically, we want the client's head, just the head, to be elevated at 30 to 45 degrees. Then we need to identify the manubriosternal angle or the angle of Louis. Then we measure the vertical distance between the imaginary line or the tongue blade and the manubriosternal angle. So this jugular venous pressure must not be more than 3 centimeters above the angle of Louis. Now, higher pressures indicate heart failure. So what exactly are we talking about? So your patient should lie flat, as you can see in this diagram, then locate the angle of Louis, and then you can draw an imaginary horizontal line. This horizontal line, an imaginary line from the angle of Louis. So there will be distended jugular veins that are below this line, and there are also the portions of the distended veins that are above this horizontal line. It is this distance that we're interested in, this distance of distension above the horizontal line. Okay, so if you look at this diagram, you can see that this ruler is going all the way up to the angle of Louis, and then we have an imaginary line there. Let me put some ink. Okay. So we have an imaginary line. I need ink. Okay. Sorry. Let's get a pen. Yes. So we draw an imaginary horizontal line there. That's the imaginary horizontal line that I was talking about. So if you're measuring this distance here, okay, essentially, remember that you have distended jugular veins below this line and above this line. So it is this distance, the distance of distended veins that are above the angle of Louis that we're interested in. So that's what we're measuring here. If this is greater than 3 centimeters, you have distended veins there greater than 3 centimeters, then your patient has raised JVP, and that is a sign of increased pressure on the right side of the heart. Okay. Then, still on the head and neck, palpation and auscultation. So we want to palpate the temporal and carotid pulses. We want to feel for the rates, the rhythm, as well as the amplitude. Now, when it comes to palpating the temporal arteries, we want to ascertain whether there's tenderness when we palpate the temporal arteries. Tenderness in the temporal arteries might suggest temporal arteritis. When it comes to palpating the carotids are found on either side of the neck. And if you just follow down deep along the sternocleidomastoid muscle, between the sternocleidomastoid muscle and the trachea, you are able to feel your carotid arteries. Very important, palpate the carotids one at a time to prevent causing a vasovagal episode, and your patient might faint if you palpate them at the same time. So palpate them one at a time. So after you've palpated them, you're trying to feel for any thrills in the carotids, which might suggest that maybe there's carotid artery stenosis, or indeed these thrills might be turbulent blood flow, which is coming all the way deep down from the heart itself. So auscultate the carotids. Then after you've palpated, auscultate the carotid arteries for carotid artery bruits. Now these bruits are audible vascular sounds associated with turbulent blood flow. So for example, if the carotid artery is narrowed, it is stenosed, okay, it is narrowed, you find that there'll be a carotid artery bruit when you auscultate. So although they're usually heard with the stethoscope, you can also feel them on palpation. And like I said, when you feel that abnormal vibration of the carotid artery with each heartbeat, you're going to call that a thrill. Okay, carotid artery thrills. Then let us look at the upper extremities. You begin, of course, with inspection when you're looking at the upper extremities. So you want to inspect the upper extremities for appearance. How are they looking? Okay. You want to look at the color. You want to feel the temperature and check capillary refill. So in terms of the appearance, when you look at the extremities, of course, they should appear, the upper extremities, you look at the palm, They should appear pinkish, not hyperrhythmic. They shouldn't appear hyperemic rather. They should just appear, they have a pinkish color. Okay, they shouldn't appear white, which could be a sign of pallor, palmar pallor. Okay, and that's a sign of anemia. So then when it comes to assessing the capillary refill, what you just do is that you gently squeeze the nail bed until it blanches. By blanching, we mean the pinkish color sort of disappears from the area where you've applied your pressure, where you gently squeeze the nail. When you release, the pink color should refill the nail bed within 2 seconds or less. So delayed capillary refill might occur in patients that have anemia, in patients that have hypovolemia, patients that are dehydrated. You'll find that the capillary refill will be delayed. It will be greater than 2 seconds. So nails should be pink with the angle of insertion normally of 160 degrees at the nail bed. So you assess for finger clubbing. If the fingers are clubbed, you find that the angle of insertion of the nail at the nail bed will be 180 degrees. And this can occur due to infective endocarditis or due to cyanotic congenital heart diseases. So you look out for what we call Shamroth's window, okay? Let me just perhaps project a Google Sheet that we can just quickly look at to so that you are able to tell when you see loss of Shamroth's window, you can easily tell that your patient has finger clubbing. Okay. So let's look at a few images on the web that can help us to identify finger clubbing. So if you look at this this picture here, let me just project it for you. Let me project this one for you. So okay, so I'm sure you're now looking at the image. Let's quickly do this. Okay, let's project this one instead. All right. So I'm sure you're able to see these diagrams here. So what you're seeing here is, let's get a spotlight going. Okay, there we are. So this is the normal angle of insertion of a nail. Okay, the nail should insert at 160 degrees. This angle there should be 160, such that when a patient puts the two index fingers together, there'll be a window there. This window is what is referred to as Shamroth's window. This is a normal nail. These are normal nails. But when there's finger clubbing, notice how that Shamroth's window is lost, because the angle of insertion of the nail is now more than 160. It is about 180 or even more. So you see this in patients that have infective endocarditis. You see this in patients that have congenital or cyanotic heart disease, congenital heart diseases. Also in patients that have had chronic obstructive pulmonary diseases for a long time, you'll find that they develop finger clubbing. Okay. Let us go back to our slides. Okay. So we've checked for finger clubbing. We also want to look for other signs of finger clubbing that I think we're going to focus on more during master's sessions. But you should be able to look out for splinter hemorrhages, look out for tar staining. In patients that smoke tobacco, you'll be able to see tar staining on their fingers. Look out for Janeway's lesions and Osler's nodes, which might be a sign of infective endocarditis. Then you want to palpate the brachial, the radial pulses for rate, rhythm, and amplitude. Normally, the rhythm should be regular, and then you also count the heart rate in a minute. okay? Particularly so for heart rates that are irregular, make sure you count for a full minute. Then on the lower extremities, you want to inspect and palpate the lower extremities, look at the appearance, basically what you had looked for on the upper extremities. Look at the appearance, the color, you feel them for warmth, okay, feel for the temperature. In patients that have shock, for example, patients that are in shock will present with cold extremities. So the extremities might be cool and clammy depending on the type of shock. But if you're dealing, for example, with septic shock, you might find that the extremities might actually feel warm. Check the capillary refill and check for superficial veins in the lower extremities. If a patient has distended veins, okay, that are tortuous in nature, we call those varicose veins. That is a vascular disorder. Then palpate the femoral, popliteal, posterior tibial, and dorsalis pedis arteries. Feel for the pulse and for the amplitude. The knot warmth of the calf, which might indicate presence of varicose veins. You can also palpate the calf to feel for any, or to assess for what we call intermittent claudication, pain in the calf, especially when the patient plantar flexes. When you ask the patient to plantar flex as if they are standing on their tiptoes, they will experience pain in the calf. That is called intermittent claudication. It is a sign of impaired blood flow through the veins around the calf. Okay, you might see that in deep vein thrombosis. Not presence of edema, which is common in congestive cardiac failure. So check for pedoedema as you assess these lower limbs. To check for pedoedema, you just apply pressure with your thumbs. You can apply pressure on the dorsum of the foot. As you apply pressure there, or just around the ankle, apply pressure for about 3 seconds. Then you release. Once you release, you may see a dimple where you had applied pressure with your finger. That is a sign that your patient has pitting edema. So once again, I think for you to appreciate this more, I'll just perhaps take us to a Google page and just show you what pitting pedoedema looks like, okay? So let's look at these images here. Okay, so I'm sure you're able to see these images here. So here, the health worker had applied, let me pick a spotlight so that you're able to see. Okay, so here, the health worker had applied some pressure for about 3 seconds or so. And then after releasing, you can see that there's a dimple that has remained. This is a sign that there's fluid that has accumulated in the interstitium. Equally, that's what we're doing there. You apply pressure. After you release, a dimple remains. That is a sign that the fluid which has accumulated in the interstitium had been pushed to the side and a dimple was formed. So that is a sign of pedoedema. Okay. Moving on with cardiovascular assessment. So we are looking at the physical examination of the cardiovascular system. You palpate pulses. It is important in assessing the status of peripheral arterial circulation. So you want to palpate the pulses. Now avoid using the index finger alone because it has the strongest pulse. It has its own pulse. So you may be feeling your own pulse that will interfere with what you're feeling on the patient. So you may also use, you have to use light palpation as you palpate these pulses. Absence of a pulse may indicate the site of a stenosis where there's narrowing or constriction of an artery. And it may suggest that if you can't feel a pulse, it means maybe the artery that you're palpating is narrowed at a point before, okay, the point that you are palpating. So it means that the coarctation is proximal to that location. Now, pulses should be palpated bilaterally and simultaneously, except for the carotid pulses, of course, so that you are able to feel for the rhythm and compare the two. So normally, left and right pulses should be symmetrical. Now, note that carotid pulses should be palpated one at a time. This I've already talked about, to prevent reflex bradycardia and reduce, also when you palpate them bilaterally, you may cause reduced blood supply to the brain or to the head. So this is the site for the popliteal pulse. You can palpate it in that manner, okay? Then we have the dorsalis pedis here. Okay, you can palpate the dorsalis pedis by palpating this area here. Okay, that is how you palpate it. Then the posterior tibial artery runs just behind the medial malleolus there, so you can palpate it in that manner. Okay. And now let us look at the final aspect of the physical examination, which involves examination of the chest and precordium. So when it comes to cardiovascular examination is in two parts, really. There's peripheral vascular examination, and then there's examination of the precordium. So when we talk about the precordium, we're just talking about the area on the chest that overlies the heart and the great vessels. So that is the precordium, the area on the chest that overlies the heart and great vessels. Now, let us look at how we can examine the precordium. The precordium has what we call topographic landmarks that you need to be aware of, and their abbreviations. So we have intercostal spaces. These are the spaces in between the ribs. So we have the right intercostal spaces and left intercostal spaces. Then we have the sternal border. This is the area around the sternum. So we have the right sternal border and left sternal border. Then we have the mid-clavicular line, right mid-clavicular line, and left mid-clavicular line. So let us look at this diagram here, and probably also get ourselves a pen. So the topographic landmarks, really, these are the intercostal spaces. These spaces that are found between the ribs, these are intercostal spaces. So those on your right are called right intercostal spaces. On your left, you call them left intercostal spaces. Then we have the clavicle, or the collarbone in layman's language. So if you draw a line that divides the clavicle into two, it is known as the mid-clavicular line. So this is the mid-clavicular line right there. So it is there both on the left and the right. So you have the left mid-clavicular line and right mid-clavicular line, okay? Now, we also have the axilla. So where the axillary fold ends there, you can draw a line, a vertical line going downwards, and we call this the anterior axillary line, meaning there's a line also in the middle of the axilla that goes down there, and we call this the mid, okay, let's rub that one, it didn't come out well. Okay, so we're going to call this one the mid-axillary line, okay? The mid-axillary line. And then, of course, behind, there's a posterior axillary line, which is really of no significance when we're examining the patient. Okay. Then this is the sternum right here. Okay, so this is the mid-sternal line or just the midline of the body. Then we have the sternal borders here. So this is the left sternal border and the right sternal border. Now, inspect the anterior chest. You begin, of course, when you're examining the precordium, you begin with inspection. So you want to inspect the anterior chest for any scars. Are there any scars? What are the contours that you are seeing there? Are there any visible pulsations? In people that do not have a lot of muscle on the chest, you may be able to see visible pulsations of the heart through the chest wall. Then apical pulse may be visible, like I said, if the client sits up and leans forward, because that brings the heart closer to the anterior chest wall. And you may be able to see this in patients that are lean, or patients that don't have very thick pectoralis muscle, chest muscles. In obese people, you may not be able to see the apical pulse through the chest wall, even if you perform, we call this the accentuation maneuver, where you ask the patient to lean forward to bring the heart closer to the chest wall. In obese patients, even if you do that, you may not be able to see pulsations through the chest wall. Okay, so check the anterior posterior diameter of the chest relative to the transverse diameter of the chest. So really, if you have a patient, let's put the head there. Sorry, the drawing may not be very good, but let's say this is the back of the patient and there's the lumbar curvature there. Oh my, this is not good at all. Okay, so the eyes are there, the patient's eyes and the mouth. Okay, now, that doesn't look so good. Let's erase it a bit. Okay. So I'm trying to draw a patient's lateral view. Okay, and of course they are standing like that. Okay, and then yeah. So this is the, let's say this is the posterior aspect. Okay, the posterior side of the patient. Okay, so this distance here is known as the anterior posterior diameter of the chest, okay, from front to back. Then on the other hand, if you have this diameter of the chest, okay, it's so this diameter of the chest right here, this one here will be the transverse diameter. So this is the transverse diameter and this is the anterior posterior diameter here. So normally the transverse diameter should be at least twice the anterior posterior diameter. That is the normal. Now in patients that, for example, have a barrel chest, you find that the transverse diameter becomes equal to the anterior posterior diameter because the chest has expanded so much, okay? And the sternum is pushed forward anteriorly. So the anterior posterior to transverse diameter ratio is 1:2, where the anterior posterior is 1 and the transverse diameter is 2. Ratio of 1:1 may signify barrel chest due to chronic obstructive pulmonary diseases, emphysema, or cystic fibrosis in children. Okay, you may also see this kind of phenomenon if your patient has a tension pneumothorax. Then as you are inspecting the chest, you also look out for chest wall abnormalities. This one is pectus excavatum, also known as a funnel chest or sunken chest. Look at how the sternum of this patient is pushed inwards. Now, this will imply that the heart is being compressed, and this might affect the stroke volume of the heart. Okay. After you've inspected the precordium, you now go ahead and palpate. How do we palpate the precordium? You just get your hand, place it over the cardinal areas. So you are looking for the pulmonic area, aortic area, and then you're going to palpate along the sternal border and around the apex. So you want to palpate around that area, which is the apex. You want to palpate along the sternal border there. And then you also want to palpate up there because we have the aortic area there. We have the pulmonic area here, and then we have Ebb's point, and then we have the tricuspid area, and then we have the mitral area, which is the point of maximal impulse. So notice how the examiner here moves his hand like that and like that. So at this point, you're palpating for the areas that are along the left sternal border there. You want to feel for any thrills and any heaves. And then lastly, you come to the point of maximum impulse. Okay, down here, you want to feel for the apical pulse to feel for any thrills. Now, we are saying a heave. A heave is a sustained thrusting pulsation, usually felt at the left sternal edge, and it indicates right ventricular enlargement. If the right ventricle is abnormally enlarged, it has hypertrophied, then you may get this heave. A thrill is a palpable murmur that is felt as a shudder beneath the examiner's fingers. Usually you get thrills over the chest as you palpate. If the patient has valvular diseases, for example, if this is a systolic thrill, then your patient has aortic stenosis or ventricular septal defect or mitral regurgitation. If you feel the thrill when the patient is in diastole, it's a diastolic thrill, then it might be due to mitral stenosis. Okay. So you use your palm, like I showed you in the diagrams, the palmar surface of your hand and also the finger pads. Gently palpate the anterior chest, allowing the chest movements to lift your hand if they're able to, okay? If you detect a laterally displaced apex beat, then that could be a sign of left ventricular enlargement. The apex beat is most prominent right here in the fifth intercostal space along the mid-clavicular line. So if it is displaced, maybe to this side, laterally displaced, then you know that the left ventricle has enlarged. That is why you're getting the apex beat on the lateral aspects. So that is how you palpate. Then auscultation, here you use your stethoscope and you listen systematically in 5 auscultatory areas surrounding the heart. I'll talk about these auscultatory areas shortly, okay, using this diagram. So let me just come to this one right now. So notice here, we have the second intercostal space in the right parasternal border. This area is referred to as the aortic area. Okay, so this is the aortic area, meaning sounds that are coming from the aortic valve here can be heard more readily in this area. Second intercostal space, right sternal border. Let me first run through these topographic areas so that you understand them. We have the aortic area, and then we have the pulmonic area here. Then we have Erb's point. Okay, this is Erb's point. And then we have the tricuspid area. Okay, that's the tricuspid area. Tricuspid. And then we have the mitral area. Okay, or the points of maximum impulse. Okay, the mitral area. So this is the aortic area. Aortic. Then we have the pulmonic, Erb's point, tricuspid area, and the mitral area. So these are the areas where you place your stethoscope when you are auscultating the chest, in particular the precordium. So you start with the aortic area so that you are able to get sounds from the aortic valve more clearly. You come to the pulmonic area. The pulmonic area is in the second intercostal space in the left parasternal border. Sounds from the pulmonic valves may be heard more clearly from there. Then Erb's point. Erb's point is corresponding to the mitral valve at that point. And so you are able to get sounds that are coming from the mitral valve, and also sounds that, because it is more centrally located, so you are able to get sounds coming from all the various points, radiates at Erb's points. Then we have the tricuspid area. The tricuspid area, though we get it in the fourth, we have second, third, then fourth intercostal space here in the fourth intercostal space in the left sternal border, left parasternal border, fourth intercostal space, we have the tricuspid area. So we are able to get sounds from the tricuspid valve more clearly in the tricuspid area. Then we have the mitral area, which is the fifth intercostal space, often in the mid-clavicular line there. So you are able to pick it in the fifth intercostal space, mid-clavicular line. That is your mitral area. This is where you get the apex beat from. So what you do is that you go through these points with the diaphragm of your stethoscope, and then thereafter, you go through these points with the bell of the stethoscope so that you are able to get the more low-pitched sounds, such as heart sounds, and the extra heart sounds, such as S3 and S4. Okay. So let's go just through the notes quickly. So the diaphragm picks high-pitched sounds, for example, systolic murmurs and early diastolic murmurs. Then the bell, that's the smaller circle on your stethoscope. The bell picks up low-pitched sounds such as heart sounds, and then mid-diastolic murmurs of mitral stenosis as well. Heart sounds are generated by closure of the valves. I'm sure you do remember that from your physiology lessons. It is when valves close that you get heart sounds, S1 and S2. So the S1 sound is produced by closure of the mitral and tricuspid valve. Simply put, closure of the atrioventricular valves. When the tricuspid valve and bicuspid valve close, then you have S1 produced. Now, notice that closure of S1 closure of the atrioventricular valves occurs just before ventricular systole. So it means that just after S1, your heart will go into systole. All right? When these valves have closed, it will go into ventricular systole. Then S2 is produced by closure of the aortic and pulmonic valves. Meaning that immediately after S2, then your heart will go into diastole. This is significant because you know that the moment you hear S1, what is following is the systole. The heart is now contracting to push blood into the aorta and the pulmonic vessels. Then after S2, the heart is resting to allow filling of the atria and ventricles. All right. Now, both S1 and S2 are heard at all 5 auscultatory points. But because of those, the location of those positions, remember, S1 will be louder at the apex over the mitral and tricuspid valve. So S1 is louder at the apex over the mitral and tricuspid valves. The apex is the lower point of the heart. Let me just demonstrate it to you. Down here, this is the apex of the heart. So that is why we are saying S1. S1, remember, is produced by closure of the atrioventricular valves, the bicuspid and tricuspid valves. These two, the tricuspid valve and the bicuspid valve. Notice that these are closer to the apex compared to the pulmonic and the aortic and pulmonic valves. So you get the S1 close, you get the S1 more. It's louder at the apex of the heart. whereas S2 will be louder at the base of the heart. This is the base of the heart up here. Okay, so S2 is louder here because it is closer to the aortic and pulmonic valves. That's what we mean here. Now, S1 and S2 are the normal heart sounds, the lab-dub sounds. But S3 and S4 are normal in children, and they may also be normal in young adults, in young adults, but abnormal in adults that are older than 30 years. So in a child, normally in a child, you may find that there are some extra heart sounds, S1 and S3. So S3, which produces a cadence of Kentucky, it occurs after S2, meaning immediately after S2, just as the heart is going to begin to feel in diastole, you have the S3 sound occurring. Now, this occurs when 80% of blood in the atria rapidly fills the ventricles. When blood rapidly moves from the atria into the ventricles, just at the beginning of diastole, you get an S3, meaning immediately after S2. Remember I said S2 is produced by closure of the aortic valves, aortic and pulmonic valves. When those close, then the heart is now resting. It is in diastole. Now, this happens when patient, for example, has fluid overload, as you may see in patients that have heart failure. Okay, patients with heart failure, they usually have fluid overload, so they may have an S3. Then S4, the Tennessee sound, occurs just before S1, meaning right at the end of diastole, just before you go into systole, before these atrioventricular valves close, then you have an S4. This one occurs in adults that have a stiff ventricle. For example, those that have cardiomyopathies, they might have an S4 sound when the ventricle is stiff. Okay, because remember, S1, just immediately after S1, ventricular systole will occur, meaning you have an opening click. You have a sound that will be produced by this stiff ventricle. Just before it, as it begins to contract, it leads to production of a fourth sound because it is stiff, it is defective. Murmurs are vascular sounds that produce vibrations. Okay, vascular sounds that produce vibrations within the heart or great blood vessels, such as the aorta and the pulmonary vessels. So the abnormal sounds are produced by vibrations created when blood flow is altered. So for example, when there's narrowing of a blood vessel, coarctation of the aorta, for example, there will be a murmur over that narrowed place. When there is an aneurysm, you might or you might not get murmurs over the area of the aneurysm. So systolic murmurs occur during the ejection phase or during systole. Then if you hear people talk about diastolic murmurs, these ones occur during the filling phase of the cardiac cycle. Now, murmurs are associated with valvular diseases, hyperthyroidism, anemia, and ventricular heart defects. Lastly, percussion. So percussion is not so commonly used. It is of low sensitivity generally. It is better to use an X-ray to determine the size of the heart than to percuss the borders of the heart. It's a very inaccurate technique. So that's all about the physical examination. And lastly, I'll just quickly talk about a few of these investigations that are done in cardiovascular system disorders. So we have a chest X-ray. An X-ray is, it focuses a beam of energy that will pass through the body and then make a picture that will be cast or it will be collected on a film. Then you are able to see. So the most common is the posterior anterior X-ray, where the rays first strike the back of the patient and then they are collected in the front of the patient. So this one, the X-ray helps us to determine the size of the heart. It also helps us to look at presence of maybe fluids within the chest. If the patient is standing, we are able to actually see fluid meniscus there. on the X-ray, okay? So normally the transverse diameter of the heart should be less than 50% of the thoracic diameter, except in neonates, infants, athletes, and in patients with a funnel chest. Let's perhaps have just a quick look at a chest X-ray. Okay, so okay, let's quickly show this. We'll just look at a Google page. All right, so I'm sure you're able to see this page. So we are saying that this, let's take for instance, this chest here. All these chests, most of them are abnormal. So when we take that diameter there, that is the transverse diameter of the chest, okay? But better taken down here. Okay, this one is showing it. Better taken right there at that point. So that is the thoracic diameter. Then this one here is the cardiac width. Now, normally, the heart should occupy not more than half the chest. So this diameter, this width of the heart should be at least half of the thoracic width. If it goes beyond that, then your patient has cardiomegaly, which is enlargement of the heart. Okay, so this is a chest X-ray and how we can use it to determine the size of the heart. Okay. Then we have what is known as an electrocardiogram. So electrocardiography, this is a graphic record of the heart's electrical activities. It shows us how the heart is pumping, and it produces a waveform that is the PQRST waveform. So I'll not talk so much about this because you covered this in your physiology. So it helps us to detect problems such as, heart block. It helps us to detect dysrhythmias. So these atrial fibrillations, for example, which are common in mitral stenosis, rheumatic heart disease, where the P wave is decreased, or you may completely lose the P wave of the PQRST waveform. Ventricular fibrillations, these are due to ventricular myocardial infarction. You may see these as a complete disruption of the normal rhythm and depression of the QRS complex, okay? There's also an echocardiogram. Echocardiography, this is it's basically an ultrasound imaging which uses high-frequency sound waves to reflect tissues onto a screen that will pass through a transducer. So you're able to see images on the screen. And this technique is used to evaluate internal structures of the heart, also motion of the heart, so that you're able to see areas of the heart wall that are weak. If at all there's a myocardial infarction, you can see vegetations. For example, in valvular heart diseases, incompetent valves can be seen using this echocardiogram. Congenital heart diseases, cardiomyopathy, congestive heart failure, so many diseases, even cardiac tumors, can be seen on echocardiography. Okay, then we have the CT and MRI. So we'll not spend so much time, and you can take some time to read some of these investigations. So cardiac catheterization, this one is a more complex procedure, but it is able to be done. I think they perform this even at our National Heart Hospital here in Zambia. They're able to perform a lot of these cardiac catheterizations where they insert a thin radio-opaque catheter into circulation. They may insert this through maybe a vein. For example, the right side of the heart is catheterized using a peripheral vein, such as the femoral or internal jugular vein. They need to be advanced all the way through the right atrium, and they're able then to visualize, they're able to measure pressures and perform a lot of other functions. So the left side of the heart can be catheterized via the right femoral artery. So that is cardiac catheterization. It is done to obtain detailed information about the structure of the heart valves, blood vessels, and the circulatory system. So oftentimes they may do this to determine problems and then go in for heart surgery after they've ascertained the problems. Blood tests. Hemoglobin estimation. This one measures how much hemoglobin a patient has, and you've done this in your physiology, so will not spend much time. Hemoglobin is the oxygen transportation molecule in the blood. So low levels of hemoglobin suggest anemia. These are the normal levels. Hematocrit is a measure of how spaced red blood cells, how much space the red blood cells actually take up. A high hematocrit level means that one is dehydrated. There is less fluid in a meal of blood. There are more red blood cells packed together. They are concentrated. So in dehydration, you will see this. Low hematocrit might indicate anemia. There are less red blood cells. Okay, or also in hemodilution, where there is maybe too much water and sodium in the body, there is hemodilution. So your patient will have a low hematocrit. Abnormal hematocrit levels might also be a sign of blood or bone marrow disorders. So these are the normal values. The full blood count is able, again, you've done this in your physiology, so we'll not spend so much time, but even blood grouping and cross-match, you've done all these in your physiology, so you may take time to refer to your notes in physiology. So in our beginning, I think we had talked about the various clinical manifestations and what they may cause. So take time to go through the differentials even as you go through these notes. Thank you so much. You can take time to also complete that assignment. Thank you.